Hello, everybody. Thank you so much for joining us today. I am Laura Doherty, the National Clinical Manager at Functional Formularies, and I really appreciate everybody signing in today and listening to our wonderful, wonderful speakers. A few housekeeping rules before we get started. This webinar is approved for one CPE unit for RDs and DTRs. The email, that certificate will be sent out to you in a separate email by the end of the day Monday. So if you don't have your certificate by the end of the day Monday, please let me know. You'll have all my contact information at the end of the webinar. If you want a copy of the slides today, they are in the handout section of the GoToWebinar platform. If you don't have access to that, you can also just let me know and I can email them to you. Everybody's going to remain in mute-only mode for the duration of the webinar. We will have a Q&A session at the end, and you can type in your questions throughout the webinar into the questions section, and then we'll get to those at the end after our two speakers. And I think that's all the housekeeping I have. So for now, I'm going to introduce our two amazing ladies that we have on with us today. Gabriella Gardner is going to get us started. She is an RD that holds an advanced practice certification in clinical nutrition. She's also board certified in nutrition support and trained in integrative and functional nutrition. She has over 10 years of experience in GI nutrition and joined UT Health Houston McGovern Medical School in the fall of 2023. Prior to her current role, she was the lead clinical dietitian at the Ertan Digestive Disease Center, where she developed the outpatient GI program and led many quality improvement projects. As a nutrition support clinician and dietitian, Gabby specializes in the management of patients with intestinal failure who may require home nutritionist support. Gabby's going to be focused on our adult research today for the webinar, and then after Gabby's finished, we're going to have Haley Riggs, who is our pediatric specialist today, jump on. She is a certified nutrition support clinician as well and holds a clinical specialty in peds nutrition. She's currently the clinical dietitian at the Warren Clinic Pediatric GI office in Tulsa, Oklahoma, where she specializes in patients with G-tube feedings, accounting for almost 90% of her patient load. Prior to this position, Haley spent 8 years working at the St. Francis Children's Hospital with her primary focus in pediatric intensive care. And with that being said, I am going to hand it over to Gabriella to get started.
Thank you, Laura, for the introduction, and thank you everyone for joining this webinar, where we're really going to dive in depth on the research on blenderized feeds. First, just wanted to show my disclosures and Haley's, and both of us are receiving an honorarium for this presentation. The objectives for our presentation are to understand the latest scientific evidence supporting the efficacy of blenderized tube feeds, identify barriers and ethical considerations surrounding the implementation of whole food tube feeding in diverse clinical settings, and also gain practical tips for selecting suitable candidates for blenderized diets, considering those individual nutritional needs and medical conditions that our patients may have. I'm going to take you first a little bit back in history. So we kind of put several things into perspective on how we got to where we are today. There are reports on the late 1500s of enteral feeds using some ingredients like raw egg, beef, whiskey, and it was on the 18th and 19th centuries where they started using more food mixtures. So it started resembling a little bit more of what we know today, blenderized tube feeds. They were still using similar ingredients with beef, whiskey, eggs, but we started seeing a little bit more of those foods. In the early 1900s, there was a lot of work in terms of the development of feeding tubes, gastric tubes. And then on the 1940s, they were looking at feeding methods other than boluses, because that was what had been previously done. So in the 1940s, they developed the drop-by-drop method, which I think right now would be more like a gravity feed. And in the 1940s, there were commercial enteral formulas being developed. So that's when we started seeing that shift on more interest on commercially prepared formulas. A group of Barron and colleagues were doing some work with both types of formulas, like tube feeds in the hospital kitchen and also commercial available formulas. And in the 1950s, Barron and colleagues published a study where they said that hospital kitchen tube feeds were better tolerated, more medically sound, more cost-effective than commercially prepared formulas. They were using strained baby foods with a fine mesh, liquefied solid foods. And some of the formulas that they were providing had 180 grams protein average and 2,600 calories. So that was one of the first reports on the use of blenderized tube feeds in the hospital setting. But in the 1960s, again, these drive for producing commercial enteral formulas and also furthering the nutrition science. They were looking at elemental formulas, amino acids, adding vitamins, minerals. In the 1960s, there was an elemental formula study that showed that patients were able to have adequate nutrition support during their hospital stay, normal physiologic function. And one of the key things was that they had decreased in stool frequency, because one of the challenges that was being seen with the use of blenderized food-based formulas was patients having more frequent bowel movements. So that was one of the things that they highlighted with the use of those elemental formulas, which we know because they are absorbed more proximally in the small intestine, there is less residue. So of course, there's going to be a decrease in frequency. Then after this study came out in the 1960s and 70s, hospital administrators really took an interest on evaluating the use of commercial enteral formulas. They saw that labor savings were substantial. There were less concerns with microbial growth, less need for kitchen equipment. They were not as concerned with the viscosity of formulas. So this is when we started seeing the shift in hospital settings for commercial enteral formulas, and also the development of specialty formulas like for diabetes, renal, pulmonary, and kind of gave birth to the model of what a lot of hospital settings have today. But in the 2000s, we have seen this increased interest in food is medicine. And there have been several movements and initiatives, even by public health organizations like the World Health Organization declared the Decade of Nutrition 2016 to 2025, because they were seeing an increase on diet-related chronic diseases like diabetes and hypertension, cardiovascular disease. So they really wanted to go back to food is medicine. And more recently, the White House released Food is Medicine initiative in 2022, where it's not only the decrease in chronic diseases, but also food insecurity and being able to provide food to the general population. But I'm pretty sure a lot of you will remember in the early 2000s, people were talking about ingredients in food labels, and you know, they were like, are those ingredients that you can pronounce? And that became a big thing. And that was no different in our enteral feeding patients, where they started looking at the ingredients contained in several of the formulas, and they wanted to have more food as part of the regimen. So as clinicians and healthcare providers, we were trying to identify how many of our patients were eating or were taking blenderized tube feeds. So the Oli Foundation did a survey. This was published in 2017. They did a survey on their home enteral patients that were part of the Oli Foundation. And they had a total of 216 participants. One thing I want to mention is that the link to the survey was mostly available through the Oli Foundation website. So it was a smaller sample size. It had some limitations because probably they didn't really get like a more participation like would have been ideal. So it is estimated that the survey only looked at about 2% of the whole home enteral nutrition population. But some good things about this survey is that they were able to capture pediatric and adult patients. The majority were pediatric. They were most likely filled out by parents or caretakers, because we can see them in age of those participants, whereas 5.4 years old, 5 years old. So probably it was the parents filling it out. But a few other highlights from this survey is that for pediatric patients, 89.6% of those pediatric patients had about 71% of their average intake coming from the blenderized tube feeds, compared to the adult group, where 65.9% the blenderized tube feeds were contributing 56% of their total nutrition. So we do see a trend of pediatric patients using more of this blenderized tube feed approach and providing much more calories than the adult population. But it was nice to see that it was present on both. But what exactly are we referring to when we talk about blenderized tube feeds? And the common the definition for blenderized tube feeds is that it's food and liquid pureed enough to be given via an enteral access device. Blenderized tube feeds can consist of natural whole food ingredients. They can be prepared in a kitchen at home or in the hospital, but there are also commercial blenderized formulas, and they may be manufactured with food ingredients or pureed foods, so they are not all the same. They may or may not have certain vitamins, minerals, and maybe other added ingredients, for example, fiber. What are some of the barriers of using blenderized tube feeds? This is, in my experience, what some of my patients have shared with me as concerns. Time commitment to prepare the formula, to infuse the formula. They worry, how long is this going to take? Do they need expensive equipment? Do they need a certain type of feeding tube? And then as a healthcare provider, some of these were some of my concerns early on my career in the area of GI. And, you know, we were worried about, is this going to clog the tube? Is my patient going to lose weight? What type of education I need to provide for food safety? Is it going to be nutritionally complete? Are they going to tolerate it? So I think that one of the primary barriers for healthcare providers to recommend blenderized feeds is the sense of lack of resources and training for dietitians on this area. And I was very happy to see Aspen coming out with their blenderized tube feed recommendations in 2023. I do want to really emphasize that these are recommendations based on evidence and expert opinion. We do not have a lot of those large trials or very strong evidence to provide more set guidelines on the provision of blenderized tube feeds. So for now, what we have are recommendations. And the goal for this paper, or released by Aspen, is to promote patient safety and some direction to clinicians, because there was this sense of lack of resources and guidance. This is a very good paper. For the purpose of time, I'm not able to go in depth on each one of these steps or recommendations, but it's a really good paper that I encourage you to read if you are considering on doing blenderized tube feeds. It really gives you information on how to choose the best formula for your patient as a patient-centered approach, whether it is commercial or the family decides to prepare it in their home kitchen, what type of access device, how to care for it, what are the things to consider in terms of administration, equipment, storing the supplies, cleaning the supplies. If you need to do a nutrition analysis, the advantage of having a recipe or using a commercial blenderized tube feed formula, challenges with viscosity, how you can overcome them. And I really like that they address the viscosity guidelines based on viscosity on the IDDSI guidelines for dysphagia. So a lot of good things on this paper, as well as the setting, you know, hospital setting, home setting, follow-up and monitoring. So talking a little bit more about how our patients can benefit from blenderized tube feeds, it does allow our patients to make those food choices, what ingredients, food ingredients, they want to add into their body. It also allows them to account for any cultural, religious beliefs, or even ethical beliefs that they may have. Maybe they want to choose more organic foods. They are able to do that. Or if they have some dietary restrictions, it's also easier to plan for that regimen as if they were eating those whole foods. It also empowers them and gives it that increased sense of normalcy, autonomy. They can make these food choices. And as we're going to show in some of the studies, improved tolerance, like GI symptoms, bowel irregularity, reflux, volume intolerances. These are common things that we encounter when providing enteral nutrition. So that's what we're also going to address in some of the studies that have been done. I wanted to include this paper by Dr. McCabe and Martindale. It's called "Why Do Current Strategies for Optimal Nutrition Therapy Neglect the Microbiome?" And this is a really good read because they're focused in critical care. And they explain that we have focused a lot on maintaining gut integrity by recommending those trophic feeds when you are in the critical care setting, starting those tube feeds, trophic feeds. But that is just going to maintain gut structure. So what about the microbiome? If we don't provide a nutrition regimen that supports the microbiome, we may be missing an opportunity to directly impact inflammatory response and possibly improve outcomes. So this paper talks about like a myriad model. They did a study comparing a whole food-based formula and a polymeric formula, and they saw that whole food formulas can directly influence the microbiome and support a healthy microbiota with more positive species. They noticed that there was lower enterobacteriaceae, which is a more pathogenic type of bacteria. Also, the presence of soluble fiber and production of short-chain fatty acids stimulated anti-inflammatory metabolites in the gut that regulated an anti-inflammatory response. So this is a really good paper. And as I was mentioning, whole foods provide fiber, and they're not going to provide you with one specific type of fiber. That's the beauty of whole foods. They are going to give you these different fiber sources. And I'm not only talking about soluble, insoluble, but all their other characteristics, you know, in terms of fermentability, viscosity, and the more variety, fruits, vegetables, legumes, like those would be ingredients that will really help support a healthy microbiome. And of course, we know all these foods are full of antioxidants, and these will be natural phytonutrients and other vitamins and minerals that the person can benefit from. I will review a few studies that focus on fiber. This first one was the effect of fiber on gut barrier function, microbiota, short-chain fatty acids, inflammation in critically ill patients. It's a systematic review. A total of 21 studies were included. 20 were randomized controlled trials, and one was a cohort study, but they all included critically ill patients. And some of the challenges with the studies that were included is that their methodology was very heterogeneous. They provided very different dosages of fiber ranging from 3 to 33 grams. So that's a big difference when we're talking about fiber. Some of them provided prebiotics or symbiotics, and the types of fiber were different. Some had more soluble or insoluble, and also the fermentability was different. So the findings from this meta-analysis were positive, but of course they were like, well, you know, fiber may improve the intestinal permeability, may improve unimpaired permeability in ICU patients. It may increase that production of short chain fatty acids, decrease enterococcus, and it may also help reduce that inflammatory response. So they saw a decrease in CRP levels, but the results were so variable that it was very difficult for them to find very clear results. This is another interesting study that I wanted to share on adult patients. This was done on healthy subjects, meaning they were not on enteral feeds. Actually, the formulas were given orally. None of these patients had a feeding tube, but their design was very interesting. It was a randomized double-blind crossover study, and they allowed the participant to be on their habitual diet or the regular diet for 14 days. Then they gave a fiber formula for 14 days, and the fiber was a blend 50-50 soluble, insoluble, fructooligosaccharides, inulin, p-hol, gamma acacia. Then they would switch back again to that habitual diet, and then they ended with a fiber-free formula. And the average amount of fiber that it provided was, well, I'll show the averages, but the formulas contained 15 grams per liter. They wanted to look at changes in stool weight, bacteria diversity, and tolerance. So these two tables, a few things I do want to highlight between habitual diet and a formula diet. So that's going to be on the top of your screen inside that red box. You will see that, especially for women, the difference in calories between habitual diet and formula diet was different, from 1900 calories to 1600. And I think this is important to keep in mind as we provide enteral nutrition. You know, sometimes a person may lose weight because they may just be getting less calories than what they would do on a regular basis than if they were eating, going about their day, eating regularly. And the other thing I want to point out is the fiber content. In the habitual diet, it was 16 grams on average, compared to the formula. The fiber intake was average 18.9 grams per day. So they got a little bit more fiber when they were on the formula. And some of the changes that they saw in output, not too surprising. Fiber-free formulas, they had the less output. They also had the highest fecal moisture, meaning they were more watery, they had more water in them. Their transit time was 101 hours, so it kind of took a little longer for those fiber-free formulas. And the Bristol stool, if any of you is familiar with that or not familiar with that, it ranges from 1 to 7. 1 is more constipation, like very solid like pellets, and then 7, it's going to be the least form, watery, like diarrhea. So you can see on the results score that fiber-free formula was the least formed compared to the fiber blend, which was 4. That is a form stool, what we would consider a normal bowel movement. So it was a normal stool compared to the habitual diet. They were also more towards the constipation side. So expected things, but it's nice to kind of see the comparison of the 3. And then in terms of bacteria population, the primary change was on bifidobacteria. The fiber-free formula had the lowest count of bifidobacteria, and the fiber blend was closer to the habitual diet. And many studies on FODMAPs, like we know that inulin and fructooligosaccharides are known for promoting the growth of bifidobacteria. So not too surprising that they found these, but just wanted to highlight some of the findings from this study. Key takeaways from these is that fiber helps to maintain regularity, good consistency, and if we provide fiber-free formulas, we're probably going to see a change on the count of bifidobacteria. This was a small sample size study. They were also young and healthy. They didn't have any comorbidities. And this is another systematic review that I want to share in adult patients. It was published, it included articles published between January 2020 and December 22. They included different types of blenderized tube feeds, commercial, homemade. They wanted to look at changes in weight, BMI, symptoms, patient satisfaction. A total of 9 studies were included, 5 in the home setting, 4 in the hospital. The majority were male, and it included patient populations like with neurological impairments and head and neck cancer. So in terms of anthropometrics, we see that there are 3 types of studies that looked at this. There were 3 cross-sectional studies. The first 2, Tanchoco et al., Xavier de Mello et al., they found that blenderized tube feeds had lower scores for mid-upper arm circumference and triceps skin fold thickness. But the first study, it was very small in sample size by Tanchoco, and Xavier de Mello, the results were not statistically significant. And then the next study, they also found that there was no difference in anthropometrics between blenderized tube feeds and commercial. So that was more of a neutral study. Then the pilot study, they looked at an RD prescribed blenderized tube feed, where a lot of those patients, the majority gained weight. So we see there the benefit of being monitored by a dietitian, but 22% lost weight. Some of the challenges with this study was that it was small in sample size, and the quality score for the study was low because of their study design and the sample size. And the other study was on commercial blenderized feeds for 6 weeks. It showed that also 46% had gained weight, but 31% had lost over 5% of their body weight. So we saw some changes on the weight, same challenges, small sample size, low quality scores. And then the last one I'm going to highlight on anthropometrics is a retrospective study by Papa Costas. This was a study in head and neck cancer patients. It had a nice sample size. They compared 3 different groups of formulas. The blenderized to feed, that was like a homemade blend. It was not very structured what ingredients were present. So that is a big factor that needs to be considered. That was the group that had the greatest decline on BMI, fat-free mass, and continued to experience weight loss compared to the RD prescribed and the commercial enteral formula. Some of these studies looked at formula differences. Again, one of the concerns by clinicians. This study by Vieira et al., it's on home tube fed patients. They saw that the blenderized tube feeds provided less than 50% of carbohydrates and protein, but commercial enteral formulas provided the recommended fat and energy, but had a higher protein content. Then we have Xavier de Mello, which is another study on home tube fed patients. And we have 3 different formulas here. We also have a blenderized tube feed where they're using food ingredients, a blenderized enteral preparation, and they were using food ingredients, but the primary difference here is that they were using protein and carb modulars and a commercial enteral formula. And we see that those that were on these blenderized enteral preparation, the protein provision was very close to those on the commercial enteral formula. So 4.2 grams per 100 grams compared to 4.26. And in terms of GI symptoms, we have 3 studies where they looked at consistency. There was a trend towards normal stool in those blenderized tube feeds compared to more liquidy on commercial enteral feeds. Same on the Fabiani et al. Study, which was in a cardiac ICU patient. They saw more diarrhea in those on commercial formulas compared to blenderized tube feeds. And the last one on head and neck cancer, besides bowel movements, they did look at vomiting and nausea, bloating. They saw an improvement on the blenderized tube feeds. In terms of patient satisfaction, 2 studies looked at those results, and one on head and neck cancer, they measure they use a survey for quality of life, and they show it went down from 37.6% to 0, meaning they improved their quality of life significantly. And then for hospitalized adult patients, 27% were satisfied with the regimen, but the majority, 73%, were very satisfied with the regimen. So I'm going to share my case study real quick so I can switch it back to Haley to talk about pediatrics. This is an adult patient, 42-year-old. She had a history of anoxic brain injury. She had a PEG. She had been on enteral feeds for 2.5 years. Prior to her injury, she had some challenges like hypertension, hyperlipidemia, but after being on enteral feeds, that's when she developed diabetes, and she had metabolic associated fatty liver disease. She was also having volume intolerance, reflux, vomiting. So family really wanted a whole foods approach, and she was at that time on already on a diabetes specific formula and a renal formula because she had a history of hyperkalemia plus some modulars. So the biggest thing with this patient was that we couldn't go above 700 mLs on her volume because of that volume intolerance. So we switched her formula gradually every 4 days. I kind of started substituting half a pouch of the blenderized to feed, whole food blenderized to feed, and we gradually replaced those calories and protein. We had to use carb-free protein modular to help meet those protein needs. But at the end, she tolerated a larger volume. She got better calorie provision and protein than what she originally was. But truly the highlight of this case study was that after a few weeks of being on the whole food blenderized to feed, she was no longer experiencing reflux. Her metabolic parameters improved. Her liver enzymes improved from her initial visit. Liver enzymes normalized after 10 months. And same with her glucose control. Her sugar levels were 365 milligrams per deciliter on her initial visit. And 10 months later, they were averaging 120. And it was also evident on her A1C that dropped from 10.3 to 5.9. So very exciting results. And I'm gonna turn it to Haley.
Great. Thank you so much, Gabby. While we're waiting for Haley to pop up her slides here, I really appreciate you taking the time. So Haley's going to talk for about 20 minutes on pediatrics, and then we'll have a little bit of time. We may go a little bit over for Q&A, but we will hang on a little bit after the 2 o'clock Eastern Standard Time to go over those Q&A. All right, Haley, you're all set.
Okay. Trying to get rid of. Okay. Well, can you guys see this little box on my screen, or is it just the slide?
I think it's just the slide. The slide looks great.
Okay, perfect. Well, thanks. All right. Well, thank you guys. Thank Gabriella for getting us off to a great start. Laura, thanks for the introduction. So let's just go through. We're gonna, continue these objectives, but in the pediatric realm. So we're gonna review some literature, and then hopefully I can alleviate some of your guys' hesitations in terms of converting over to blenderized tube feeding from my experience. So this first article we thought was a good place to start. It was published about 2 years ago. Most of these articles are from 2018 to 2020 from Schmitz et al. It's just an integrative review. The research question was, in children who depend on enteral nutrition, how does blenderized tube feeding compare to commercial feeding in terms of nutrition composition, health outcomes, and family satisfaction? In terms of nutrition composition, there's 11 total articles reviewed. Only 2 studies in the review investigated the nutritional composition of the blenderized tube feeding used with the children, which I think speaks to sometimes the difficulty in terms of analyzing these blenderized tube feedings when they're home blended. They did, in Gallagher et al., patients did receive guidance from the dietitian in terms of prep and provisions, and they also gave prescriptions and assessments, followed these patients for 6 months. In that particular study, they did find, in order to maintain a stable BMI, calories when on the blenderized tube feedings were 50% higher than the commercial enteral formula. This is conflicting in other studies that we'll talk about later on as well, but in this particular one, they did mention that they thought the calories needed to be higher. In terms of, micronutrient content, the vitamin D content in the blenderized tube feeding was typically lower than the RDA. The authors recommended just like a enteral supplement for additional vitamin D. And then the fiber intake was significantly higher in the blenderized tube feeding, much to like what Gabriella was saying with the adults. In terms of health outcomes, all the reviews, they maintained appropriate growth. There was never any concerns or questions in terms of like weight gain. The impact of introducing whole foods, total of the blenderized tube feedings or partial, was evaluated in 6 studies. And I think it's important to note, and just as you know, Gabriella was saying in those Aspen guidelines, not all of these blenderized tube feeding studies are necessarily 100% blenderized tube feeding, which in my review of the studies was very interesting because as you see, we're going to see some results, but it doesn't have to be an all or nothing situation. It's just partially introducing some of the blenderized tube feedings. There was less propensity for viral diseases and improvement in children's immunity. Which if you work in an outpatient setting or even an inpatient setting, everybody's goal is to keep kids out of the hospital, keep kids from getting sick. I have a case study later on that we might review that it just ends up putting a wrench in a lot of different things when we continue to get illnesses, especially at like wintertime. I mean, in my setting in the GI clinic, sometimes I'm not making changes in wintertime because that's going to be interrupted by viral illnesses and stuff. So any way we can avoid that, improve on that, that's always a good thing. And then in the review, there was a reduction in nausea, vomiting, diarrhea, gagging, reflux, constipation, abdominal pain, and better tolerance of the diet volume. So basically everything you could ask for in terms of, you know, feeding tolerance in enteral kids. Some of the interesting, I think, mechanisms, you know, a lot of this research is blenderized tube feedings help with these certain or produce these certain outcomes, but I do think it's interesting as to the why, like why are these things happening? A little bit of some of like what Gabriella mentioned as well. So in this review, some of their, you know, hypotheses in terms of the mechanisms for this improvement in their GI functions, slower gastric emptying secondary to the viscosity, which we've talked before. Increased fiber, like Gabriella said, can improve symptoms. Another interesting thought was with these blenderized tube feedings, you know, back to metabolism, the chyme that would reach the small intestine reaches it at a rate that is more physiological and stimulating more of a regular hormonal response to, you know, receive these nutrients and process them and move on. So I think that that's very, very interesting. In terms of family satisfaction, you know, answering their research outcomes or the research question. And if anybody, you have worked in pediatrics, you know, you're not just satisfying the patients, you're satisfying the parents. So I think this is a nice, you know, look into some of the reviews. Positives, being able to provide real foods, reduction of symptoms and intolerance to tube feeding, obviously. Greater oral intake, and that's seen in a lot of different reviews, and we'll talk a little bit more about that later. And having family meals, you know, I think a lot of the parents feel a lot better about providing real food, and it's similar to like what brother's eating, similar to what mom's eating. We feel like we're all eating together. Some of the negatives that we're seeing: longer prep time, potential nutritional inadequacy of the diet, feeding the child outside of the home, so kind of like convenience, storage, and then possible tube obstruction in terms of like clogging. These are things that Gabriella even mentioned. These are things that come up often. So we'll look into some of those a little later too. Of note, one of the studies reported only half of the parents received support from the healthcare team in terms of providing like a prescription for blenderized tube feeding and supervising it. I think Gabriella hit it on the head in terms of knowledge, and I think that speaks a lot to how difficult it really is to assess these blenderized tube feedings and like make changes. I mean, I feel like it could be a whole new course that we could all take if we wanted to like be blending these at home for sure. So this next study is Kernizin et al. It was published in the Gastroenterology Nutrition in 2020, and I was drawn to this study. I think it's very straightforward. It's something I'm familiar with. It's, you know, chart reviews basically from this pediatric GI clinic, Rutgers Robert Wood Johnson University Hospital, you know, looking at why we switched over to a blenderized tube feeding and how these patients reacted, which I think is very clinically, you know, it's helpful. This is what we want to do, you know, and we want to see what's happening practically, you know, out in the world. So in this article, there was 35 medically complex patients between 1 to 19 years of age. Tube feeding types, most of them were G tubes. They had 2 GJ tube patients. I do want to note, I mean, the patient population that was independent of their underlying like comorbidities, the majority of them had like a underlying genetic disorder or cerebral palsy, which for any of you working outpatient, especially in pediatric clinics, that's a lot of what you end up seeing. And so that's not surprising. I do think it's interesting they did not exclude any of these patients that were eating orally. So I think that's a very interesting thought and result that we are seeing from some of these reviews is the oral intake. So baseline formulas, most on whole protein cow's milk formulas, 6 were on elemental formulas. In terms of medications, so 33 patients were on GI related medications for GERD specifically, and then constipation or upper GI dysmotility, most commonly being like a PPI. In terms of, so not listed, GERD was the #1 reason to transition these patients from like a commercial enteral formula to a blenderized tube feeding. This bar graph shows you the symptom improvement after initiating that. Again, total number of patients, 35. And then some patients did have more symptom changes in more than one symptom category. So if you're looking at the graph, pretty self-explanatory. So symptom improvement for GERD was the highest symptom improvement, which is wonderful. You know, GERD, I think, is the tip of the iceberg for a lot of other symptoms that you're finding, and it's not a benign, you know, diagnosis. It can lead to much further problems being left undiagnosed or uncontrolled. And then I think interesting, this PO intake was the second improvement in terms of, you know, switching to a blenderized tube feeding diet. Interesting to note, you know, the length of time on the blenderized tube feeding was 1 to 45 months, with the mean being 15. So this, you know, and we'll see this later on too, it's not a necessarily an immediate result, which is sometimes difficult to navigate. So most common improvement is GERD. 13 of the 33 patients were able to wean or stop their GI related medications. And for those of you working GI, you know, those PPIs are not benign as well. So they can lead to other causes with bone mineralization and things like that. So these are not something we want to have these patients on forever and long term. 2 of those J-tube fed children were able to actually transition to G-tube feedings, which is always something that is helpful and always something that is a goal. You know, J-tube feeds come with their own set of problems, and in terms of like getting back to normalcy, we want those feedings going through the G. And then 5 patients showed improvement in PO intake, with 3 receiving all feeds by mouth at the end of the study, which I think is very interesting. The longer I've worked in a GI outpatient setting, the more often that's my goal. I think I underestimated the amount of patients that are actually, you know, using G tubes for supplementation, and our goal is to get them off. And so that is always what I'm pushing for, is to get these kids to be eating more by mouth and get off these G tube feedings. So I think that's really, really interesting and really encouraging in terms of like, can I give them a formula that is helpful in terms of letting them eat more, you know? Again, some of the why for the increase in PO intake, which I think is interesting, of course, the decreased GI symptoms, changing in the gut microbiota, which is what Gabriella touched on too. This can be related to appetite signaling. So changes equal more increased appetite, which is very interesting. I hope we can hear more about that at some point. And then motivation by caregivers, you know, I think that's a lot of just like getting over the hump is like, maybe if we have an increased appetite with these blenderized tube feedings, then we're seeing more appetite, and then we're more encouraged to, oh, here's more food, here's more food, here's more food. So almost just like a motivational scenario. This last study is, my notes say I saved the most intense for last, but this is through Boston Children's, Hran et al. A pretty big study, I would say, in terms of like pediatric studies. So these were done through the hospital. Health outcomes and quality of life indices of children receiving blenderized tube feeding for enteral tube. So 70 children. Again, to note, the blenderized tube feeding group was greater than 50% of their diet was consumed from homemade table food or commercial blenderized tube feeding formula. So again, it doesn't have to be 100%. This is just the table of the study population. Just important to note that the varying comorbidities, there wasn't anything significant. They do touch on the no significant difference in the calorie when you're comparing the commercial formula to the blenderized tube feeding. Like I said, that's kind of been an inconclusive result from some of those earlier reviews. And again, you know, growth was stable, no significant changes in growth or weight gain. In terms of healthcare utilization, ER visits were reduced by 43%, 53% reduction in total admissions, 67% reduction in respiratory admissions. This is the bulk of like the things that set you back, I swear, in the wintertime when you're really trying to make some headway in terms of weight gain and GI tolerance. So just by switching formula, that's helpful. And then in terms of GI related symptoms, again, GERD frequency and severity was the closest to or significantly improved, and then nausea and vomiting, abdominal pain, upset, and diarrhea as well. Again, they talked a little bit more on the mechanisms as to why this, you know, why we're seeing these improvements. Increased viscosity, which is what some other people have theorized to improve reflux, similar to, you know, for us in the pediatric world, thickening to infant formula for like infantile reflux, helping that keep, you know, process. Quality of the macronutrient composition, which I think is where, you know, prescribing home blenderized tube feedings for me becomes overwhelming and kind of nerve-wracking, is it's like not necessarily the total amount of the calories and the protein and things like that. It's about the specific quality of the macronutrients, you know, slowly digestible carbs with legumes and whole grains versus corn syrup and things like that. The vitamin blends with your fruits and vegetables, diet fiber versus, you know, they are not, just like how Gabriella was saying. And then the dietary diversity increases intestinal microbiota. And I swear this is where like a lot of this research is going, is with that microbiome. And this specifically talks to the dietary fiber making a impact. This is just a list of other specific patient populations in terms of pediatrics. Just article reviews for aerodigestive patients, short bowel disease, short bowel syndrome, young patients, all seeing improvements with blenderized tube feeding. And then we don't have much time at all, so I have a couple case studies that I'll just review super quickly. This one, really the important thing to take away from this is I switched this patient. She was an 8-year-old, you know, 33-weeker, cerebral palsy, chronic respiratory failure. She did have a GJ and was on elemental formula, and we changed her because of her gastric emptying, continuous diarrhea, awful diaper rash. We did it slowly. But the important thing to take away here, I think, for a lot of people, is she was on an elemental formula, and we switched her to like a peptide-based blenderized tube feeding formula, and her bowel movements decreased, her rash improved, her reliance on GI medications, she was able to wean some PPIs, no changes in weight. She actually gained weight, and it's beautiful. And then real quick, I have this last case study. And really what I want to point out here is that this is a 5-year-old heart failure, secondary to cardiomyopathy with a heart transplant. So this is a very, specific population of kids that you worry about their health and their immune health and their immunocompromised situations with him being on like an immunosuppressive drug. But he ended up, we switched him for poor weight gain, and I was really hoping to help his, immune system. So he started out for the first 4 years just trying to drink, like a polymeric formula, and then we got a G tube, switched to like a standard plant-based, and then I ended up seeing him, in May or so, we switched him to a blenderized tube feeding. April, right before I saw him, he had ear infections, noro, astro, EPEC, strep, C. diff, all the things. I'm just like clawing at every single thing I can do to try to help this kid's immune system. So over time, again, August, he had COVID. He went on a cruise and got COVID. And then in October, he had pneumonia and had post-tussive like vomiting and abdominal pain. November, he had flu and strep. But the important thing to take away from here is that it finally started to see some improvements come February of this year. His vomiting improved, solid stools, his appetite was getting better. Last time I saw him, it was in May, and his vomiting and appetite and formed stools again were all improved. So takeaway message here is that it took an entire year due to other variables, all those other illnesses, to try to finally see some benefit, which we are seeing in some of those reviews, being on a formula for a mean time of like 15 months. It just takes some time. So don't let your providers give up on your blended tube feeding. In terms of limitations, these are things that we see throughout a lot of the research. I would hope going through some of this literature can alleviate some of these limitations and hesitations for you guys, like on the fence, in terms of like switching from an enteral commercial, enteral formula to like a blenderized tube feeding formula, or even a blenderized tube feeding formula commercially made. J tubes, really, there's no problem. As you can see in some of my reviews, some kids can get off of J tube feeds and go to G tubes. The conflicting evidence on estimated calorie needs, increase versus no increase in need. On all the studies that I've reviewed, there was really no change in growth. That's, our biggest outcomes in terms of pediatrics. There's really been no change in growth in terms of like just from commercial to blenderized tube feeding. Home blended diet and recipe variability, it is very difficult to assess and can change frequently. I have a few patients that do these things at home, and they're doing something different every time they come in. So it's hard to keep the consistency and difficult to assess. I mean, we have the databases and things like that, but it takes time. And then sanitation and costs. Aspen has sanitation guidelines for home blended tube feedings. Those are out there. You can always recommend those, educate on those. In terms of cost, I mean, when you're doing these things at home, it is not necessarily cost effective in terms of like you're purchasing food, you're purchasing, blended or blenders that are commercial blenders to make sure you're getting that blend the right way. Of course, I had this, discussion with a family recently. With commercial blenderized tube feeding formulas available, you can alleviate a lot of that cost in terms of insurance covering these commercially blended tube feeding formulas that now we're not having to, do these things at home. So again, really, I think the biggest hesitation and limitation for dietitians in this situation is time. So, I mean, with families, it's like home blending, prep food, prepare the food, shop the food, you have to do all these things, and that is time in itself, and that's their commitment, their thing to worry about, what they want to do. And so it's definitely a discussion to have with these families. But in terms of RD assessment, like I said, this could be an entirely new, I feel like you could get a degree on like home blending tube feedings, because there's a lot of assessment that's done, and it's not done quickly. You have to get those recipes from families, what they're doing, and then adjusting it, or where do you even start when you start your own recipe. And then just like some of this literature says, it's about the quality of the ingredients, or about the certain number of fiber. And so that's very like, what numbers are we using? It's very tasking and overwhelming for me. Family approved changes, extra training in terms of quality ingredients. So RD assessments is time. And then time to see improvement. You know, does your patient have time to, you know, spend a year working on making improvements, or the consistency? My question is like, is giving the same recipe that works over time consistently, is that what's helping us improve on these, you know, GI symptoms and things like that? So final thought, I mean, I think there needs to, you know, be a shift to orient around transition patients from oral to tube feeding, you know, without compromising nutritional integrity, food by mouth to food by tube. And, you know, I have a background in like breastfeeding research, and this reminds me a lot of that, especially for those pediatric people out there. You know, we had a time where formula was like the next vet. That was amazing. We were like so excited and this is wonderful. But then over time, you know, a lot of research is saying, well, actually, you know, breast is best, breastfeeding is best. This is what's natural. This is what's, you know, coming. This is what was meant to be given to these babies. And so that's where a lot of the formula research has come from. And I think this is the same exact thing where it comes from. We're all recommending breast milk because it's the most natural. It's the most, you know, physiological thing that these patients can have, and the same thing for food. Just the food is what is our bodies were meant to have.
Great. Thank you so much, Haley and Gabriella. I know we are over on time. I apologize for that to all the attendees. When you have two passionate speakers, it is bound to happen. We do have one person that was waiting for a question for a while, so I will actually address this one. Just clarifying on one of the studies that Gabriella talked about, the Spurlock study, which is the head and neck cancer study. I believe the slide talked about like overall anthropometrics, but it's important to keep in mind and that the first 2 weeks of that study, the patients were on the commercial formula, and that's when the weight loss happened. Once they were switched over to the blenderized, they either gained or maintained their weight, except one person. So the overall weight was changed, but it really shifted positively at that 2-week mark when they switched over to the blenderized tube feeding. So I did want to provide some clarity since we had a few questions on that. Anybody else that has a question, we do have a few minutes that we can answer. If not, feel free, I put this in the chat, email me directly. That's ldoherty@functionalformularies.com, and I'm happy to get your question answered by Haley or Gabriella or both of them, you know, through an email type of chain. Haley, if you want to switch to like a few more slides, you will get a copy of all of these references in the slide deck. You will also get a separate copy of all the references when you get your certificates. In addition, we have some other upcoming CPEUs for RDs and DTRs and other healthcare providers. We actually have one in 2 weeks. The speaker for that is Dr. John Van Mulo. And then we have one in August as well. So you can register for those if you're interested. Yeah, so that's it. If nobody has any questions pulling in, that's great. But again, you can email me. I'm happy to get those answered. Thank you, everybody, for your time. Thank you to Haley and Gabriella for sharing your expertise, your knowledge, your experience, and most importantly, your passion. So appreciate both of you. Okay. Well, with that, I don't see any questions coming in, which is great. It means everybody thought that was amazing. So I will go ahead and sign this off for everybody, and everybody can have a great rest of your afternoon. Thank you.
Thank you.